What I'm going to talk to you about is how we plan our mammography screening to be most effective. Those of us who do mammography are doing it more often. We're doing it on more women, and we are increasingly becoming conscious of the costs involved, not only because of internal pressures but also external ones. What I'd like to share with you this afternoon are experiences that we have had and some of the experiences of others in planning the best strategy for dispensing screening to large numbers of women. I'm going to be reviewing with you first the rationale for using one versus two view screening in the baseline situation, that is the first time a woman undergoes screening. Then after we finish with that, we will talk about subsequent screening examinations because the answers turn out to be slightly different in the two situations. First, let's talk about baseline screening. Now, we have to start out with the realization that as we begin to do more and more screening, we must think of screening not simply in the conventional mode where women who are asymptomatic are intermixed with women who are symptomatic in the usual patient flow situation, but rather in the low-cost, rapid throughput setting. This approach is becoming more and more widely used as time goes on, and especially as we are faced with external pressures to get costs down. Using this approach requires us to limit our goals in screening to detecting abnormalities rather than fully characterizing them. And this, in fact, is perfectly appropriate when you are performing a screening examination. The only goal of a true screening exam is to find out whether there's an abnormality. You then go beyond that with additional testing. This type of examination, therefore, is limited to standard views, and what we're going to talk about is what the standard is. Of course, cases that are interpreted as abnormal require additional images at additional expense. I will share with you results that we have had at UCSF with a controlled retrospective series of 2,500 consecutive asymptomatic women, all physician referred, none of whom had prior mammograms. So these are truly baseline examinations. And what we did was our standard examination at that time, it actually still is, but our standard examination was 2 views per breast, an oblique and a craniocaudal. But we initially interpreted only the oblique images, one on each side, made an interpretation, and then subsequently made an interpretation of both the oblique and the craniocaudal views to give an assessment of whether one view would give us the same answers and how that would affect patient management. Interpretations were done blind, in random order, all by the same radiologist, myself. The interpretive criteria, which are those that are used in rapid throughput screening, are either normal or abnormal. There is no middle ground, just normal or abnormal. Abnormal requires further evaluation. Normal requires no further evaluation. The parameters that we assessed in determining whether there were differences between single and 2-view screening were number of abnormal interpretations, the number of mammography-generated biopsies, because this, of course, will affect overall cost, and number of mammography-detected cancers. That's what we're out to find. First observation that we made was that there were a substantial number of abnormal interpretations on single-view examination that were not corroborated on 2-view exam. Here's an example, a particularly striking one, of how this comes about. Standard examination, single view, would involve simply an oblique projection mammogram. On this image of a primarily fatty breast, I think you all can appreciate that there looks like there's a poorly defined mass in the upper outer aspect of the breast, the top of the breast on the oblique view. This would have to be called abnormal, was not present on the opposite side. So the single view exam is interpreted as abnormal. when it is viewed together with the craniocaudal image, which was taken at the same time, the two-view exam, you can resolve that single confluent density into a group of rather unimportant looking parenchymal densities rather than a single solitary mass. So under these circumstances, especially with experience in reading screening exams, the two-view exam is called normal, because what we are dealing with here is a superimposition of benign structures rather than a true mass. This is the most common cause for abnormal calls in reading screening mammograms, and certainly is the most common cause for reading abnormalities in a one-view examination. Another situation which pertains, not as frequently, but also does come up, is the issue of calcifications and where they're located. Standard oblique view mammogram shows a tiny cluster of calcifications in the mid portion of the breast. Here on the right-hand screen you can see them photographically enlarged, and there are 5 or 6 clustered calcifications. On a single view exam that must be read as abnormal, because it certainly looks like it's within the parenchyma. On the other hand, in examining the craniocaudal view, in this case, fortuitously, the calcifications are imaged immediately adjacent to the skin. Dermal calcifications are uniformly benign, so this initially abnormal interpretation is converted to a normal one simply by the addition of the second standard image. Another way that a single view abnormal can be converted into a two-view normal reading without the need for any further images. Let's look at the bottom line statistics. Remember, we were looking at these 3 parameters. With one view reading, we read 3.5 times as many abnormal cases as we did with the more standard two-view approach. 3.5 times more abnormals interpreted. Another way of looking at this is if you start out with a single view reading and then supplement it with the additional view, a lot of those abnormalities will be found to be inconsequential. What about biopsies generated by mammography? Well, it turns out that we would have generated 7 more biopsies with a two-view reading than with a single view study. How many of these 7 turned out to be breast cancer? 2 of them. Finding 2 breast cancers per 7 biopsies, approximately 28% yield, is a perfectly acceptable biopsy rate in the screening setting. In fact, it's one that we all hope to achieve. So that the bottom line in terms of efficacy here is that two-view reading is a little bit more sensitive. It finds a few more small breast cancers than would be found with a single view reading. These 2 cases involved cancers that were located so far peripherally in the breast that they simply were not included on the standard oblique view image, but were included towards the edge of the film on the craniocaudal views. This is a sort of situation which is unavoidable because no single image of the breast images all the breast tissue. If we are to summarize our experience with one-view screening, what are the advantages and the disadvantages of it? Well, the advantages of single-view screening could be lower film costs. You're using only half the film, so it's got to cost less. There are a fewer biopsies for lesions that prove to be benign, and benign biopsies don't do women any good. There is a lower radiation risk to a certain extent. You're taking half the films. And you also can achieve more rapid throughput, and that's one of our goals in doing low-cost screening, because if you take only half the pictures, you can get more patients through per unit time. There's still one other thing not shown on this slide, and that is that image interpretation is a little bit more rapid because you're looking at fewer films as well. These are the advantages or potential advantages. What's the downside? The advantages of the two-view screening. Well, certainly there are fewer callbacks for abnormal interpretations, 3.5 times fewer callbacks for abnormal interpretations. And then again, there are more cancers detected. Now let's look at these and try to pair them off. Well, there's no correlate on the other side for this. Let's talk about radiation risk for just a second. The radiation risk involved in mammography, as is now recognized, is a negligible risk. It's a risk that is comparable to average risks that women undertake every day in living their daily lives. Getting into a car and driving to work, if you commute for more than 40 miles round trip, you are taking just the same risk as you are in having a mammogram that day. There are a whole host of similar day-to-day activities that are similar in risk to a mammogram, so that the radiation risk of either a single or a two-view examination is negligible. This is not a particularly important entry in the column of advantages because the total radiation risk is so low. Let's look at the others. Well, let's look at the yield of breast cancer and the biopsy rate. I think we've alluded to this already. You will have a few more biopsies for benign lesions, but you also will have a few more biopsies for breast cancer that otherwise would have gone undetected. Non-palpable breast cancers that would have to wait another year or at least until the next screening examination or until the cancer grew large enough to be palpable to be discovered. So if you're weighing these two together, the advantage goes here. The advantage goes towards the two-view exam because we're not generating an inordinate number of biopsies to find very, very few cancers. This brings us to the bottom, to the last conclusion, and that's weighing the costs. The costs of less film and more rapid throughput and also decreased interpretation time against the added costs that are involved in calling back women for abnormalities. Now we know in this situation, calling women back for abnormalities at full price is a lot more expensive than reading a low-cost exam as normal. The cost of a full-purpose, general-purpose, problem-solving mammogram around the United States is a little bit more than $100 per exam. So the cost of callback is substantial compared to the small savings that can be achieved here. We did a careful analysis using our own screening program as a model of how much lower the film costs would be, how much we could save in throughput, how much we could save in interpretation time, and we came up with a figure that's just about $4.20 per patient. When you match that with the costs of the callbacks for the large number of abnormal interpretations on single-view screening, you find that this turns out to cost a lot more than $4.20. It costs about $19 per patient. So the bottom line in figuring on the economics is that it is cheaper to do two-view screening. It's about 4 times cheaper to do two-view screening than it is single-view screening. For this reason, we concluded, and others have done similar parallel studies, they've been published in peer-reviewed literature, this is the procedure of choice for baseline screening. You find more cancers, it costs less money. Now, let's proceed from that to subsequent examinations, where the situation is a little bit different, and I'll show you in several ways how it's a little bit different. We call this second screening. It also could be third or fourth or fifth screening, but let's call it subsequent screening mammography. Should we still be using two views, or in this situation, can we get away with one? Well, let's see. Again, a study, in this case involving 1,000 consecutive women. These are women, all of whom had a normal baseline two-view examination. They then have a second screening examination involving both views. But, again, we will follow the same course of first looking at just the obliques and then looking at the oblique plus craniocaudal to assess the difference in the ability of single versus two-view screening to find breast cancer. We also added one other bit of analysis to this study, and that is that we categorized our cases by Wolfe parenchymal patterns and also by absolute breast density. We did this because we recognized the problem with superimposition to be a substantial one. It occurs in baseline screening, and it also occurs in second screening. And it's a common substantial problem, and it is just basic good sense that women who have more dense tissue have more of this dense tissue to overlap itself and create superimpositions than women with fatty tissue. So that women with dense tissue might well have more callbacks than women with fatty tissue, and that might affect a decision of whether to involve single-view screening on the entire patient population or just a limited number of women. Well, let's see what we did. First of all, we broke our patients down into the Wolfe patterns are pretty obvious, and most people are very familiar with them. Our density classifications are as follows. These are mostly fatty breasts, less than 5% density by volume, as estimated visually on mammograms. These are breasts that are about less than a third dense, usually 20-25% dense tissue. These fall into the 1/3 to 2/3 dense category, about 50% dense tissue by volume. And these are the greater than 2/3 dense breasts, on the average 75-80% dense tissue. Those are visual estimates. This slide didn't fall completely, but I think what you can appreciate is that in doing our interpretations, we are comparing the baseline two-view study initially with simply an oblique second study, and then later comparing the baseline two-view study with an oblique plus craniocaudal second study. Criteria for interpretation, the same as before, normal versus abnormal, and of course we can categorize what the abnormalities are. As you'll see, they turn out mostly to be masses. Follow-ups would involve either additional mammography, ultrasound, biopsy, or some combination of these. And we started out with 1,000 patients. Abnormal on one-view exam, single-view exam, 66. Two-view exam, 17. We're seeing the same phenomenon that we saw initially. The one-view exam has many more abnormals, about 3.5 times as many abnormals. And here are the remainder, the women who are abnormal only on the single-view examination. These are actually the most important ones in our analysis of costs, but I'll get to that in a minute. First, let's examine the women who are abnormal on single-view exam, all women. Well, this 66 out of 1,000 calculates to 6.6%. This is a much lower number for second screening than we observed in the baseline situation. Why is this number lower? Well, there are two major reasons why this occurs. First one is that some lesions detected on baseline examination have already been taken care of. They've been biopsied. They're no longer there to be seen the second time. The second, more common situation is that lesions read as abnormal on single view have already been worked up as being normal. I'll give you an example of how this occurs. Here's our baseline screening exam with a small dense area on the oblique view, read as abnormal, but resolved into superimposition by lack of its visualization in the correct region on craniocaudal view. So the two together are read as abnormal, where the single view is the two together are read as normal, where the single view would be read as abnormal. That's the baseline exam. Now here we have the baseline exam and the second screening exam. And again, we see the same superimposition. It's no bigger. It looks just the same. Why should we read this second screening examination as abnormal, even though we have only one view, when it is unchanged in appearance from the same picture, and we know from previous situation that this resolved into a superimposition? This is a normal second screening single view exam, but would have been an abnormal baseline single view exam. That's the second major reason why superimpositions are not called abnormal the second time around, if you've got a good prior film for comparison. And of course, a corollary to this is when you do screening, always try to get your old films. If you can move that slide up, you'll see that when we classified our patients by density, that they fell into fairly even categories. The bulk of the patients were in the mid-density range, but just a little less than half of them were in the first two categories, and a little bit more than half of them were in the denser categories. If we can't get that one in there, what it shows you is that the single view abnormals, this is second screening, were concentrated mostly in the women with dense breasts, as common sense would lead us to believe. The denser the breast, the more likely we are to see these superimpositions causing abnormal shadows. And indeed, as you go from the least dense to the densest category, you find these percentages increasing progressively. There is a slide here which should be dropping as well. When you look at the Wolfe pattern analysis in the same 1,000 patients, you find a similar breakdown. But in looking at abnormalities by Wolfe classification, you see that this neat increase, progressive increase in finding abnormal exams does not pertain. The most likely pattern to have abnormalities is an intermediate density P2 pattern, and actually the densest pattern, the DY, has fewer abnormals than one of the less dense P1 patterns. So this correlation is nowhere near as good as that from absolute density. We'll talk about that when we get to a cost analysis later. Of our 17 patients, abnormal on the full two-view exam, this is 1.7% of patients read as abnormal, second screening with a first screening normal. 5 of them needed only follow-up mammography to be resolved into the normal situation. 1 of them had a simple cyst diagnosed by ultrasound. 5 of them had outright benign biopsies, 1 more with atypical duct hyperplasia, and 5 breast cancers were found. The same 5 breast cancers detected on two-view screening were also detected on single-view screening. And we'll get back to that point because it's an important one when we get to our conclusive analysis. But let's concentrate now on the remaining 49 patients. These are the women who were abnormal only on the single-view second screening exam. These are the women who would have been called normal had we been doing a two-view exam, but would have been called abnormal if we had been doing only a single-view exam, so-called false positives, as a result of the one-view approach. Well, the vast majority of these were masses, and the vast majority of these worked out to be superimpositions. Just about all of the masses and the developing densities and areas of architectural distortion were all superimpositions. Some of the calcifications were also superimpositions. And the craniocaudal images were sufficient to exclude the presence of abnormality. Let's look at an example to see how we work this through, because it's not intuitively obvious. We start out with a baseline oblique view that is read as normal. The craniocaudal view, which you haven't seen yet but are about to see, was similarly normal. Here we have the second screening exam, just the same projection, and lo and behold, there's a new mass in retroareolar location. It wasn't present before, but here it is now. We have to call that abnormal on a single view second screening. Let's now look at our craniocaudal view. Here's our two-view craniocaudal, our two-view second screening, that oblique plus this, and that new mass that we saw there should be somewhere in here. It's in the immediate retroareolar zone, but we simply don't see it. It fades into what looks like normal glandular tissue. And what is more, when we compare this normal glandular tissue with what we had previously, it's no different. So again, a superimposition can cause an abnormal second screening exam if it is a different superimposition than might have been present on the baseline exam. Anything new is going to be called abnormal. The majority of these situations occurred in women with dense breasts, as you might expect, because there's simply more dense tissue to overlap. Now let's look at our results for the 49 women who have these one view only, the so-called false positives, that are a function of single view screening. And again, when we correlate with density, we find a very good progressive correlation of increasing numbers of these cases in the women with denser breasts, very few of them in women with primarily fatty breasts, and none at all in the women with just about all fat in their breasts, as you might expect. The correlation with Wolfe criteria, again, is not as good. So that if we are to plan strategies, screening strategies, to offer single-view screening, it should be only for the women with more fatty breasts and not for the women with denser breasts. We will have to do the actual cost analysis to see where the breakdown is most favorable. But just remember this chart. The fewer of these abnormals we have, the more cost-effective will be single-view screening. Well, to summarize, we've got advantages of one-view screening and disadvantages. These apply to both baseline and second screening exams. There are fewer expendable supplies in a single view, less wear and tear on equipment, more rapid throughput, shorter interpretation time. These all relate to cost. Then there are the increased or induced costs that result from callbacks for abnormals. These are the so-called one-view only abnormals that would not have been called abnormal if you'd started out with a two-view exam. And of course there are fewer breast cancers detected. Now, for the baseline situation, when you calculate the numbers in costs, the reduced operating expenses for single view, you save $4.20. The increased callbacks cost $19. So it is a more costly approach to do single-view baseline screening. Not only does it cost more, but you miss some breast cancers. That's why this is not the procedure of choice. What about for second screening? Well, we don't have a good answer to this. We don't know quite what the sensitivity is, at least based on the study that we've done. We had only 5 cancers in our study. They were each found with both single-view and two-view exam. We don't really know whether the sensitivity is impaired as it is in baseline screening. Actually, there's no reason to believe that we wouldn't get exactly the same result, because the reason why these breast cancers are not found is simply because they're not included on film. So it would stand to reason that there will be a slight decrease in sensitivity. We just didn't have the numbers to be able to show it. We either would need a larger consecutive screening series or a series of selected patients that was much more heavily weighted with cancers. Neither of these is in progress, at least by us or anyone that I know. So I suspect this question will be unanswered for a while. On the other hand, our study is adequate to make an assessment of cost. Let's look at 2 potential strategies for applying single-view screening. One strategy would be to have single-view screening only for women in the so-called mostly fatty category, women with 5% or less dense tissue, the almost entirely fatty breast. Well, we had no increased callbacks in this group. So when you compare the reduced operating expenses of $4.20 to the increased callbacks, you have a favorable situation for single-view screening. You're saving $4.20 on each woman. On the other hand, that only involves 11% of the women who are being screened, because most women have denser breasts than that. So when you apply it to the entire population, you wind up saving only about 50 cents per woman screened. That's a very small number. You can actually develop a more effective, at least a more cost-effective strategy by applying single-view screening to all women who have less than 1/3 dense tissue. This is the first 2 of our density classifications. You will find some increased callbacks in this group, still a very small percent, but you will involve a much larger segment of the patient population, so that although you will only save $2 per patient, you'll be saving this money for almost half of the women. So that it turns out that this strategy saves almost $1 per patient, where this one saves only about 50 cents a patient. I hope you get the sense that although this is a little bit more cost-effective than this, but neither one of them save a lot of money. $1 per patient is a very small amount of money considering the overall costs of screening. How do we resolve the situation? Well, solely on a cost basis. Remember, solely on the cost basis. Women with denser breasts require the two-view approach because it's simply more expensive to do a single-view screen. Women with fatty breasts, at least up to 1/3 dense, will save some money, not very much, but some money on single-view screening. On the other hand, we don't yet know what the magnitude of lower sensitivity is for single-view second screening. And we probably won't know it for a period of time. And in the absence of this, what I think is very important information, and in the face of a very small saving, it has been our conclusion that we will persist with doing two-view screening, not only in the baseline situation, but also for second and subsequent screenings. And with that, I will leave you. You've had a long day, and I think it's time to go home.